We've been talking you up as the expert, the man to go to in terms of low vision in the country, if not the world. How'd you get into this, first of all, and tell us about your life's history in low vision?
Well, I got into low vision back in the 1970s, believe it or not. Basically, I had a private practice outside of Poughkeepsie, New York. And at first I went into vision therapy. I thought I would enjoy working with children. I found out that just wasn't for me. And so I started learning how to do low vision and take care of most of the low vision patients are seniors, and just found that it was easier and nicer and just enjoyed it.
Paul and I know Paul's going to want to talk about this. We always say, thank God for average, meaning we're not average, and neither are you, and neither is Adam for that matter, but he's an MD, so what does he know? But we're saying in the optometric profession, a lot of people will fit contact lenses, do eye examinations, and be very happy. And they don't do vision therapy, low vision, medical optometry, various other areas, fitting scleral lenses. And how could you not do low vision services? I incorporated it into my practice. I had a general practice. It was very easy, and I became sort of an expert. What's your opinion on the doctor who doesn't either treat that low vision patient and doesn't even refer to a low vision specialist? I mean, the culture of optometry, why is it such that they don't do what they actually learned at least a little bit in school?
When I talk about the culture of the profession, the ophthalmic, I don't care if optometry or ophthalmology, if you look at the magazines, Optometric Management, Ophthalmology Management, Review of Optometry, if you look at the CE courses that are being given over the last 20 years, 95, 98% is all medical. And so for me, it looks like the culture of the profession is the diagnosis and treatment of eye disease and the prevention of vision loss. But unfortunately, the culture does not include taking care of those who have already lost vision. It just doesn't happen. When I was director of upstate clinics at the Lighthouse in the 80s and 90s, at the Lighthouse in Westchester, New York, it was a killer getting referrals. And it's been like that for my entire career in low vision, getting doctors to refer to low vision. So when I
go
ahead.
As far as referrals, I have to take you back to Bill Feinblum. Bill, we knew each other. As a matter of fact, Bill was a referral source to our contact lens practice because he didn't want to fit contact lenses in his practice. For those that don't know William Feinblum, just a quick bit of history. He is probably, would you say he's the father of low vision for optometry?
He is the father of low vision for optometry, yes.
And how did he get into low vision? He besides being super bright and also having a PhD, he got some publicity in, I think it was Look magazine. Before Life magazine, there was a magazine called Look. And they had a whole article, a long article on Bill Feinblum in that magazine. And he had an office practice on Park Avenue. So it wasn't that he had a street location. And Bill built a low vision practice based on not referrals necessarily from optometrists, that's why I remember, but the fact that he was able to be a master in public relations to get his name around as the low vision expert. And that kept him going for many, many years. Okay, well, sorry to monopolize, Richard.
No, not a problem. As I said, I had a practice outside of Poughkeepsie, New York, and I ended up partnering with another practitioner in Poughkeepsie. And he said, "You do low vision?" I said, "Yes." And he said, "I have a friend who does low vision." He said, "Who's that?" He said, "Bill Feinblum." I said, "Get out of here. You know God?" So it turned out that Bill Feinblum actually had a home right across from Poughkeepsie and went to Vassar Temple where Phil Moselle and I went. And so a few days later, I got a phone call from Bill Feinblum inviting me to pass over dinner at his house. And after dinner, he sat me down in his office and said something that I will always remember. He said, "Richard, don't be afraid to make money in low vision. the more you make, the better you will do it. And I have followed that ever since.
You know, one more history story, and then I will shut up and let you start talking. When I was teaching down in Florida for a short time, there was always a complaint that it should be the low vision center of the world with all the seniors that are in South Florida. And people just didn't get referrals. And I said, this is absolutely crazy. So my mother was then living, this was in the early 90s. She was in a very upscale senior residence. And I said, well, I'm going to talk to these senior people and see what's holding up getting these referrals from seniors. So I said, in those days I was still a youth. So I had, we had, Irv Borish was living down there, and he used to come to the school. So I said, Irving, let's go and speak to some seniors. But then Irving Borish was a senior, so people could identify. So we went there. We had a whole large group of seniors, and they were so delighted to hear us speak about low vision, and people saying, "My goodness, it would give me a whole new life. I can start reading again. How it's wonderful." And then we said, well, would you be willing to pay for it? Now, this was an upscale place. Mm-hmm. And they said, well, do you mean Medicare doesn't cover it? I said, no, it might cost you a couple of $1,000s, but you'd be able to read again. You'd be independent. She said, well, no, we can't do that. And I said, look, it's costing your kids a fortune to be here. Why would you want to pay for this? She said, I'm waiting for a rainy day. I said, you're in your 80s and 90s. It's raining. You know,
rainy day.
You're saving it for. So.
The rain's about to stop. In fact, it's funny. I was a director of low vision, Rich. I don't know if you know it, Robert Wood Johnson, University Hospital for 3 years. I started the program, and then my practice just got too busy. And I think the retinal specialists are very fertile. They want to refer. Hello. They want to refer that person with 2100 best acuity or 2080 best acuity or even 2200 because their regular doctor referred them or whatever they ever got to them doesn't want to see that patient again because they can't help them. And so they love to, in quotes, dump on you. But when they dump on you, you're helping that person. And suddenly not only the floodgates open, as you're saying, in terms of that low vision patient, but you're going to get the rest of the family. You're going to monitor his pathology, whether it be macular degeneration, diabetic retinopathy, and refer back to the retinal specialist when care is needed. So there's a whole area that opens up. And I can't take let's say the OD, who is somebody who's 20/80 best corrected acuity or 2100 and says, go to the drugstore and get a magnifier. To me, that's, I don't know how bad that care is, but it's done more often than not, as you know.
Well, I hear most of my patients saying nothing more can be done is what they're told.
Yep.
And the major question is, why didn't somebody tell me that there's low vision services? So while it sounds good that retina doctors like to refer, it's been my experience that they just don't have the time. They're seeing 50, 60, 70 patients a day, and to take 30 seconds and talk about low vision can kill another hour of their day.
You're absolutely correct. They have to defer to the nurse who says who gives the presentation. And if you operate in there, if you work in their facility, it's easy. If you're making money for them and you're somehow splitting it. But if you're in your own private facility, you're correct. That extra 30 seconds of presentation, go to Dr. X, go to Dr. Y, is difficult. But if they get results and people come back happy, then they start thinking, maybe I can get this patient off my back because my anti-VEG treatments are just keeping them stable and not getting better acuity. So there's at least something I could do for them. But for example, in New Jersey, we have the ability to, through the library service, the person comes into the office, first thing I say to them is, okay, I'm going to get you a digital cassette recorder. You can get any book, any magazine for free through them. And here, take this home, this demo device, and now, what's it cost? No, it's free. It's free through the safe services in New Jersey. I'm sure they have that in other states. So the point is, you can start helping a person right away with simple things like templates and a device like that, and then get on to the bioptic telescopes and the Geordies and the Merlins and the Aladdins and things like that if they're able and willing to pay. If not, sometimes you get them help anyway.
Well, my experience, I when I moved to California in the mid-'90s, I happened to have seen a low vision patient in a practice I was working in, and she wanted to drive. So I did the research and fitted with bioptic telescopes, and she got her license. She was 84 years old, and somehow the newspaper got a hold of it in the San Bernardino area of Southern California. And this was it was actually December 31st, 96. I remember it very, very well, because over the next 3 days, I got 150 phone calls for people who wanted low vision glasses. They were tired of magnifiers. And after speaking to 5 or 6 people and realizing they had already been to low vision services, or they at least tried and were given hand magnifiers, they wanted glasses. So I just had to come up with some new idea of how to take care of people in a private practice, because in a private practice, it's different than the lighthouse or a clinic. In a private practice, not only do you have to take care of the patient, make sure they're satisfied, but you also have to make a living. Mm-hmm. And I knew that it wasn't covered, so I wanted to make sure they knew they were going to have to pay for it. I also wanted to know that I could actually help them if they came in. So I formulated like a 5-minute telephone conversation to make sure that I could actually know that I'm going to help them. Try to get the idea of how much acuity, what kind of work they wanted to do, what kind of tasks, let them know how much it's going to cost. It worked very well, because I filtered out those who I could not help. I referred those who couldn't afford to pay to clinics. And the people that came in could afford me and were willing to spend the money. And that's now 25 years we've been doing this. Then I trained other doctors in how to do the same thing that I was doing. I came up with a 12-step low vision exam that would take 1 hour, because again, in private practice, you don't have the time to take 2 hours like we did at the Lighthouse and bring the patient back 3 and 4 times. We couldn't do loaners. You can't do loaners in a private practice. So I set up a whole new model of taking care of patients in a private practice that was actually financially viable. Most of my patients spend $3,000, $4,000, $5,000 without batting an eyelash, because they know before they come in what it's going to be like.
But if they get results, it doesn't matter. They're happy. $5,000.
Yeah, I have to have demonstrators of all sorts of devices, telescopes, microscopes, filters, prisms. I've got to put it on them and make sure they know that it works before we go ahead and order anything. I don't hope that it's going to work.
Do you use any of the high-tech electronic devices? I'm not talking about the reading CRT screens, but the devices that people wear that are self-focusing, things like that. Do you get into that at all?
I have. We have some autofocus telescopes. I have the Iris Vision. I've got the Geordie. We have access to eSight, A-Sight. We have access to all of these things. Because there are 40 doctors now in our group, we have a little bit more ability to negotiate with the manufacturers to get the demos in the office. You have to have demos to show a patient. So we've been able to do that. And sure, if a person has the acuity level that optics isn't going to work, we go to electronics.
You'd be amazed, Adam and Paul, what is out there that you probably aren't aware of in terms of the electronic devices. But, I mean, you can get, I brought, when they allowed you to do it before 9/11, I brought the Geordie into a football game. And I was watching the quarterback's face from like 1 foot away or 2 feet away. And I was up in the upper decks. It's amazing the resolution and the magnification these things have in color.
So up on
I've been wearing bioptics at baseball and football games for the last 20 years. It's just fabulous. I love them.
And in fact,
that works. I'm sorry. Go ahead.
I was just going to say, up on the screen right now, so people can see, I put up Iris Vision's website so people can see, sort of how this has gone high tech, right? One thing that
you got to remember, if optics works, it's going to be easier for a patient to put on a pair of glasses than to put on an electronic head-borne device. Mobility is much better. It's just easier for them to maneuver and have it be comfortable than to have an electronic. But if optics doesn't work, then you have to go to electronics.
Sure.
You brought me back. If I don't want to change the topic a little bit about the difficulty getting referrals and how low vision how retinologists don't have the time to refer. And we had that problem first going into practice in the 60s, believe it or not, with getting referrals from ophthalmologists for post-cataract patients for contact lenses. And we didn't spend the time courting the ophthalmologist as much as the chief office manager to do the promotion for us. And the magic word with the office manager was Tiffany's. That every Christmas they got a little box from Tiffany's with a memento in it, and they never forgot our practice. And through the office managers rather than the physicians, we built up a major referrals in aphakic contact lenses before the implant came, of course. But that is anyone that wants to go into low vision, don't bother with the retinologist. See who's running the show there as far as the office is concerned, and take them out to lunch. Don't be afraid to do some promotion, and that's helpful to practice.
Yeah, that works.
If it's done, Paul, in a setting most like an orthopedic surgeon and a physical therapist, where the orthopedic surgeon owns the physical therapy place, and they're symbiotic, it works well in a university setting or a big institutional setting where the low vision doctor is working with the retinal specialist, because then they're motivated to, let's say, have him see the patients. And if it's not him, like the nurses will do it also. So it's amazing how 50, 60, 70% of the patients get to the low vision service there, while if there's nobody there, like Dr. Shuldiner says, 1% get in. It's the same. It's human nature, unfortunately, and human nature sometimes is not the best.
But the market is so large that you don't need 100% of the people. That if you just get 20% of the low vision cases, you're doing very, very well. So you don't need everyone, and the market's going to increase mainly because the baby boomers now are getting into their 70s, and they're going to have many more low vision. And whereas the older folks that used to be part of the depression mentality, we're saving for a rainy day, the baby boomers want the very best, and they don't want to lose their vision. So I think the market can increase just by the market of baby boomers needing the service versus the World War II people who have now died off.
And we're living longer, and therefore these diseases of old age and even middle age are not happening more. Even to the point that I know you don't like dealing with children, Rich, but the people with RP and Leber's amaurosis, things like that, those people at choroideremia, those people can still be helped also. And it's a question of, it's different devices for them, but that's usually these are people that have had the disease for many years. They might have developed at 17, 18 years old, and now they're 35 and they can't drive, etc. We can help them a great deal.
Well, the biggest problem we have is just getting the referrals. So I've been trying to get the lecturers who speak on macular degeneration and glaucoma and whatever else to refer to low vision to the 100 or 200 ODs that are sitting, listening, and learning. We just can't ignore vision loss as something that has to be dealt with. We are the vision profession. We should be doing something about it.
You know, one other thing, though, I wonder how much the people that are doing low vision have to blame for not getting the referrals. A true story. A cousin of mine, who's now about 92 years old, called me and says, "Hey, I'm having trouble seeing and reading, and the doctors can't help me anymore. What can I do?" I said, "Well, you have to see a low vision specialist." And he was living in South Florida. And I tried to look up who were the diplomates in low vision, and I couldn't find anyone. So finally, I called my nephew Barry, who was still in practice, so he might know someone. And believe it or not, his advice was, don't go to any low vision specialist outside of the lighthouse. So it seems that the easy road for many optometrists is to send them directly to the lighthouse rather than a private practitioner. And I wonder if the private practitioners are marketing enough to the average practicing optometrist? What are they doing?
40 doctors in our group are marketing like crazy. I've been teaching them to do that. So we use print advertising, television advertising. What I've been trying to do is to get a general optometrist or ophthalmologist to simply say to the patient, there are low vision doctors out there. Go and Google low vision. Because if they Google low vision, at least they're going in the right direction. At least they know that there's low vision services out there. And our organization, the International Academy of Low Vision Specialists, we market like crazy. So we will come up on Google searches.
So how does somebody join this International Academy of Low Vision Specialists? What do you have to do?
You have to be trained by me. I spent 4.5 days with intensive training, training a doctor exactly how to do low vision, how to be a low vision doctor. A low vision patient sitting in the chair is not the same as a primary care patient. They have completely different set of psychological things that are going on. You've got to understand what they want, what they need, what they're not telling you, what their expectations are. So I train that. I train how to do a specific low vision exam, 12 steps, so that you can get the person help quickly and efficiently and be able to make a living doing it and help the patient. So all of the doctors have been trained specifically by me.
Yeah, in your office?
We come to California. We spend 2 days in my home doing a lot of work on the background, on the magnification, on the devices, on the optics. And then we spend 2 days in the clinic. We actually do a lot of low vision exams and dispensing, so they see exactly how it works.
That's great.
Yep.
That's good to know.
Yep, and I have it up on the screen right now, so everyone can see the URL to go visit if you want to check it out. www.ialvs.com, and the doctor directory is right there too, as promised. And I'm pulling it up here so people can see it. So pretty neat.
Rich, I'm going to do a quick promotion for ODwire. If you want to reach a lot of optometrists, I strongly urge you to start writing on ODwire.org. We have 24,000 members. And if your name were better known and the field were better, I think there would be many more referrals coming in and more people would want to join the association.
That's correct. And if you start a thread, we will support you. I will chime in my expertise, etc., and I'm sure Paul and some others will. So we get a lot more motivation, and we do have a lot of docs from that area of California that would make it very convenient.
Okay, thank you. That'd be great.
Yep,
the URL is ODwire.org, and just try to get in, and Paul will vet you, make sure you're not an ophthalmologist from China, and let you come in.
I think
Thank you.
One thing that might be useful to do as well, once CE Wire is all in the can and done, instead of just letting these electronic lectures go away, we could take one or two of them and just repost them on ODwire as well for the broader mass of doctors who, even though they couldn't get credit for it, watching on ODwire, it might be nice for them to see your talks, or at least an excerpt of each one, so they can really get a sense of what's out there, right? Since I think a lot of docs don't know.
Sounds good. Sounds very good.
All right, great.
Okay, it should be interesting.
Excellent. Well, thank you so much for coming here today, and thank you for participating in CE Wire. And I hope you've had a good experience with the lecture so far. I'm sure you're going to get a bunch more questions both today and in our final show in June.
I love it.
Thank you
very much. I appreciate being part of it tremendously. Thank you very much.